Hello, everyone. This is Dr. Oliver. This will be a continuation of our topic of hospice and palliative care. Specifically, this PowerPoint will talk about what is the difference between the two. The objectives for this PowerPoint is to understand the definition of hospice and palliative care, to understand the basic history of hospice and palliative care, and to understand the differences between hospice and palliative care. A lot of you have probably come in contact with hospice patients through your clinical practice. However, there's many people that don't fully understand what the purpose of hospice is and how that's defined. So hospice, it's considered to be a model for quality, compassionate care. And this is specifically for people facing life-limiting illnesses, and more specifically near the end of that life-limiting illness, the progression of it. So hospice is very focused on an interdisciplinary approach to medical care, and not just medical care, but also symptom management. And what that means is that there are multiple hands in the bucket. So, this can be different for every patient. Pharmacy may be involved, nursing staff may be involved, medical providers, sometimes chaplains are involved, sometimes a massage therapist is. They even have people that specialize with pet therapy or counselors. So there's lots of people that can be on this interdisciplinary team, and their main focus is to promote quality of life and compassionate care for this person that is in the end stages of their disease. We really focus on not only their physical well-being, but also their emotional and spiritual well-being. And so we try to support that in whatever way the patient needs. So it's very specifically tailored towards each individualized patient. So at the center of hospice and palliative care is the belief that all of us have the right to die without pain and with dignity. And that's very important for a lot of people, because if you really get down to what people fear the most about death is, one, they fear the unknown. So they don't know how it's going to happen. Some people even wonder what happens after this life. A lot of people come from different beliefs. And so you have to understand that everybody will be a little different with that. Also, people are afraid of dying without dignity, meaning that they're having to rely on other people to take care of them when maybe normally they were the strong one. And so a lot of people fear that. This care is also focused on the family, because the family will also go through many emotions as their loved one is going through the end stages of their disease progression. And so hospice care is not just for the patient, but it's also to support the family. Medicare began covering hospice costs as a bundle program in 1982. So just a brief discussion on the history of hospice. It actually is really interesting how hospice came into effect. It actually used to be a profession that was looked down upon. Not many people wanted to get into hospice care because the subject of dying in general was a taboo topic. So there was a lot of kind of pushing those people to the side. They were kind of hidden from other people. People really didn't want to have any part in that process of them dying. So a lot of people, unfortunately, died very, very uncomfortable, and they typically did not have any support or any comfort with their symptoms that they were experiencing. So hospice care began as early as the 11th century, and hospice became more clearly defined in the 20th century, and that's because of many great nurses that really started to hone in on what hospice was and what that did for other people. So really, London was the main center focus for this in history, where hospice began to take form. So hospice started to become recognized in the United States in the 1970s. Now, if you listen to the other palliative care, specifically more so about palliative care PowerPoint, I included this definition. So the World Health Organization really has done a great job as far as defining what palliative care is. Palliative care and hospice are very similar. However, palliative care can be started earlier in the progression of a person's chronic disease. And it doesn't always mean that we're solely focusing on end-of-life care. Some of those people in palliative care can also seek curative type care as well. So specifically, this falls in with cancer patients. We may not know if we can cure their cancer. However, there might still be some hope that we possibly can cure it. And those people are still appropriate for palliative care. So palliative care, it focuses on improving the quality of life of patients. It also focuses on supporting families as well as the patients through any problems that may be associated with their life-threatening illness. We start to identify goals of care. We identify what suffering looks like for them and what quality of life means to them. And we focus on that physical, that psychosocial, emotional, spiritual being of that person. So let's talk specifically about palliative care history now. So palliative care has always been a part of hospice care. Palliative care is really just comforting someone. So to palliate means to comfort. And so as you can see, that really fits into the ideals of hospice care. It really began to separate a little bit from hospice in the 1980s. And that's when it was first recognized in the United States as a separate form of care from hospice. The American Board of Hospice and Palliative Medicine was officially incorporated in 1996, and then a palliative care subspecialty became official in 2006. So it really was not that long ago. Palliative care has really come leaps and bounds over the last 10, 20 years. So if you break it down and make it very simple, palliative care and hospice programs differ greatly in place, timing, payment, and treatment. And we'll go over each of these individually here in a moment. I've always felt that this picture does a good job explaining. So palliative care versus hospice care. So palliative care is aimed to anyone who has been diagnosed with a life-threatening illness. And like we spoke earlier, it really can be started at any point in the progression of their illness. Hospice care is mostly aimed at patients who have been diagnosed and they're in that terminal stage of their illness. So, again, we focus on that dignified death, that hopefully pain-free death. And hospice care can be administered anywhere. And palliative care is like that as well. Most of the palliative care services right now are more inpatient focused because unfortunately a lot of the times it's a money issue. It is it's a lot more cost effective to give palliative care while someone is in the hospital. It is very expensive to run and start a home palliative care program. So a lot of palliative care programs will have an inpatient portion to it where they see patients when they come and they are hospitalized. And then they also kind of tag on a little palliative care outpatient clinic. And I've been a part of one of those that I had started in Findlay, and it is a lot more cost effective. However, a lot of the times these palliative care patients, they're referred to us later on in the progression of their disease. They may not necessarily be hospice appropriate, but they're definitely more progressed than when they were first diagnosed with this disease. So a lot of them have a hard time traveling to the clinic. So ideally, something has to change within our system so that people can have access to palliative care in their home if that's what they need. And things are progressing to that point. It's just, there's still a lot of things they need to fine tune with the system as far as how that can be done for people. So let's talk a little bit more specifically about place of care. So hospice is typically in the home. That's one of the selling points for hospice is a lot of people do not want to die in a hospital. They want to be around their family. They want to be around their pets. They want to be in their natural environment. And hospice has the capability of doing that for them. There is different levels of care. And while a person is receiving hospice care, they can have people come in and help them in the home, or maybe their home is a nursing home. And so hospice is able to come there. A lot of them contract with some of the SNFs around a certain area where that hospice program carries out their business. It can also be delivered in the hospital. So if their symptoms really are not controlled and they meet a set criteria that is of guidelines that are set by Medicare, they can actually be admitted to the hospital and they still fall under that hospice umbrella. So it's not like if they revoke their benefits and go into the ER, they go in as a general inpatient hospice patient. So they are still allowed to be in the hospital because we need to be able to be a little bit more aggressive with their symptom management. So the inpatient is not as common as the care in the home, and more so that is because people have abused the system in the past. GIP patients actually generate a lot of money for hospice companies, and so back 10, 20 years ago, a lot of physicians were and other providers were trying to get their patients on GIP status so that they could make more money. So that's why Medicare has more strict guidelines on that now. So palliative care, it usually starts in a facility, and that can be, they can initially see a palliative care provider in the hospital or maybe a SNF, and that's usually where the patient is first diagnosed. That is ideal. I will tell you that does not always happen, because a lot of the times we would get referrals from primary care providers, and the patient maybe was diagnosed a year or two ago, and now the primary care provider just does not know what to do with their symptoms, or maybe doesn't know how to have that conversation with them about goals of care, and so then we would get consulted because that is our specialty. So sometimes that happens. Palliative care is usually in the home or the nursing home if that's what they call home. However, like I was saying earlier, a lot of palliative care programs, specifically I would say out here in Ohio too, they see those providers in the hospitals at first. Out in Illinois and some of the states more out like towards the west side of the United States are a little bit more developed in their palliative care, and so they do have more avenues and more places for people to receive that care. So timing of care is probably the biggest difference between the two. So hospice, in order to be appropriate for hospice, you have to see a provider, whether that be a physician, an NP, or a PA, and they have to certify that if the disease would take its natural progression, so what's documented in research as a natural progression of that disease, it is expected that the patient will not live more than 6 months. Now we know that some people, and it's always those old ladies that last forever when we expect them to die 2 months from now. Sometimes that can happen. However, with our best knowledge, we can say that if it was a natural progression, then they would not last more than 6 months. And that is enough to certify them for hospice so that they can receive those hospice benefits through Medicare. Now, palliative care, so there's no time limits or restrictions, and that may change in the next, decade or so. But for right now, there is no time limit or restriction. So that moment that person is diagnosed with a chronic illness, they are actually appropriate for palliative care at that time. Now, like I said, a lot of people do not get referred to us that early on. Usually once they start having symptoms, or maybe they start having some issues where they need to make some end-of-life decisions, that is typically when people will call us in, because a lot of providers do not feel comfortable having that conversation, or they do not feel comfortable in dealing with some of those symptoms. Payment for care is also a big difference. So hospice is typically covered by Medicare, and it's covered as a bundle. So, all of these services are paid for in a bundle form. And most insurances too now will have a hospice program that people can sign up and pay a little extra for, so that then they will also have access to some bundled care whenever that point comes. It's also bulk billing is what we call it. So, a physician isn't going to submit a bill for their visit and then the nurse submit a separate bill. Everything is given in one lump sum for the month. And so that's a little bit different than palliative care, because palliative care is covered by regular medical insurance and each item is billed separately. So when I would go see a patient in the home, I would send in my separate billing for that visit. If, say, home health is coming in, then that would fall under that home health bundle. Or say my palliative care patient was going to go and see their primary care physician, then that primary care physician would bill separately for that visit. So it's not a bundled program. Treatment. So hospice and palliative care are very similar in what treatment they offer. Both focus on comfort care. However, palliative care, it does allow patients to still focus on curative treatment. So these patients are allowed to stay and get dialysis. They're allowed to receive chemotherapy or radiation. A lot of the times hospice patients will not be able to receive chemotherapy unless it's palliative, so meaning that it will help relieve some of their symptoms. And typically that palliative type chemotherapy is in like a lower dose and lower frequency. But some patients are still approved to receive that. It's expensive. And remember, they get paid, hospice gets paid as a bundle. So a lot of them don't want to cover things that cost extra money because then they won't get paid as much. And that goes for the dialysis as well. So each hospice is individualized in that some will allow people to still complete maybe one dialysis treatment a week to keep them comfortable. And then other ones will say, no, we don't allow patients to continue any aggressive or curative treatment while on our service. So that's why it's okay for patients to shop around for different hospices, and palliative care programs too. You can always shop around and see what's out there. So palliative care really focuses on symptom management and that comfort care. So we have to be creative a lot of the times in how we treat those symptoms. Now, one thing that hospice care has that palliative care doesn't is it has levels of care. And we talked just a little bit about this when we were discussing places of care, but hospice care has routine home care, which is provided to the patient wherever they're living. The other thing that they have is respite care. So if the family if they just need a break, they need some time away, or maybe they have a small like family trip that they have to go to, maybe their niece or nephew is graduating and they want to go to that, then respite care allows that to happen. So, they will, for a certain period of time, typically I think it's up to 10 or 15 days, it changes. And I know Ohio is different from what Illinois was, but they will provide 24/7 care. And usually they are contracted with different hospitals and nursing homes. And so they will transport the patient to that nursing home or hospital where they can be watched 24/7 until the family comes back. And that's just kind of a nice benefit for families because it is a lot of, it's a lot of hard work when you're taking care of someone that is in the end stage of their disease. The other care is that general inpatient care. And typically, a lot of hospitals are developing inpatient units where hospice patients can go and the staff is specialized to take care of them appropriately. But like I said, it takes a lot of documentation. They have to meet a strict criteria in order for Medicare to approve this. Continuous care, that is provided to patients during a crisis period. So and that's usually they will do the continuous care before the general inpatient because they really want to try to prevent having to transport a patient, especially if they are in a lot of pain or their symptoms are out of control. So a lot of the times if they meet that criteria, because this also pays hospice extra money, so they have to make sure that they are showing why it's needed. But they can provide 24/7 nursing care in the home. But typically they have to recertify this every 24 hours. So it is a lot of work to have a patient on continuous care. I liked this picture because, if you start at the person there, the little figure there, there's different routes that people can go with their illness. So, if they have a serious illness and they are doing curative treatment, they could do palliative care. And say you have someone that is, has a diagnosis of lung cancer and it's unsure, before they start treatment, whether they would make it or not. We have to see how they handle the treatment. The goal through palliative care is that maybe we get them in remission, or maybe they'll be self-sufficient and, have their symptoms maintained and, they're able to have that quality of life. Or maybe serious illness with the curative treatment, they go through palliative care, but then it really is just it's not working out for them. They're not tolerating the treatment isn't working. So it turns into more of a like end stage life limiting illness. Once they get to that point of where the provider can certify that they possibly have less than 6 months to live, then hospice care would be appropriate, and that is where end of life care will be carried out.